Hi, I am Dr. Andersen, and I will show you how using personalized ventilation as a routine in my ICU helps me manage common problems with ventilation, such as asynchrony, over-assist, and over-sedation. Personalized ventilation helps me reduce ventilator days, sedation needs, and ventilator-induced complications in my patients. My 3 imperatives for successful ventilation are: let the awake patient actively participate, monitor the neural respiratory drive, and have easy procedures that everyone in your team can follow. Let's look at how personalized ventilation works in 5 easy steps. Personalized ventilation begins in visual contact with the awake patient and an assessment of the electrical activity of the diaphragm. To do this, I always insert the EDI catheter as early as possible. It picks up the signals sent from the brain to control the diaphragm. The EDI catheter thus allows me to monitor and assess the respiratory drive. I can then decide if the patient is within the range of non-invasive ventilation. I always consider non-invasive NAVA the gentlest therapy because the patient's respiratory center is now steering the ventilator, breath by breath, in real time. Could ventilation get any more personalized? Leakage will not disturb NAVA therapy as it is in sync with the respiratory drive. I can also immediately and accurately see how my clinical interventions affect the patient. Now I observe the patient and adjust the NAVA level to keep him on comfortable support. This allows me to use minimal sedation. Since the patient is awake and the ventilation is in sync with his needs, the diaphragm can work as intended. The patient can also show me if he wants less or more assist. Because the patient is actively participating, we can gradually reduce the level of ventilator assist. The patient literally starts weaning himself from the first minutes of NAVA ventilation. I also encourage early mobilization to enhance recovery and restore the patient's physiological strength. I keep an eye on the awake patient and the EDI to decide when to free the patient from the ventilator. To make sure his breathing is fine, I continue to monitor the EDI. Should the EDI rise, this is an early warning indication of increased patient effort. With these 5 steps, I have implemented personalized ventilation in routine use. The simple procedure and easy-to-use tools allow my whole team to participate, while mistakes and wrong handling are prevented. Non-invasive NAVA is always my first choice. Should I be forced to intubate, I use invasive NAVA, applying the same simple methodology. I have found that patients who are ventilated with NAVA are weaned sooner. For me, personalized ventilation with NAVA is the best and most important change that has happened to intensive care in my long career as a doctor.